السلام عليكم. في البداية طبعا بتوجه بالشكر لكلية الطب جامعة الإسكندرية على دعوتهم الكريمة، كلية الطب جامعة الإسكندرية قسم الكلى على دعوتهم الكريمة إن أنا أكون موجود مع حضراتكم النهاردة، وبنشكر شركة أسترا للسبونسرنج الميتنج بتاعتي. في الحقيقة أنا هتكلم عن موضوع مهم جدا النهاردة اللي هو الهايبركاليميا مانجمنت in patient with chronic kidney disease and congestive heart failure. And the title of my presentation is Lokelma, a new era for hyperkalemia management. Usually we ask ourselves why hyperkalemia a treatment barrier for patients with CKD and heart failure. As we see, cardiorenal patients are at increased risk of hyperkalemia. Advanced stages of chronic kidney disease, up to 40 to 50% of patients have hyperkalemia. In patients with heart failure, up to 40% in patients with severe congestive heart failure on spironolactone may have some sort of hyperkalemia. In diabetic patients, 17% over 3-year period, and in patients with resistant hypertension, especially on MRA therapy, up to 8 to 17% may have hyperkalemia, and in general population, especially old age with multiple drugs and comorbid condition, 2 to 3% of this population may have some sort of hyperkalemia. Reduction in the estimated GFR, usually a risk factor for hyperkalemia with other comorbidity may be myocardial infarction with reduction in the GFR, usually have higher risk for hyperkalemia. In patients with heart failure, in patients with type 2 diabetes, and patients with chronic kidney disease. Also, high serum potassium is usually associated with increased mortality and adverse outcome in patients with CKD and congestive heart failure, as we see, with higher level of potassium above 6 milli-equivalent per liter. Usually, the mortality and major adverse cardiovascular event is usually increased either in patients with chronic kidney disease or patients with heart failure. And recurrent hyperkalemic episodes are common in CKD patient. As we see, if we got a patient who got hyperkalemic attack one time, they usually susceptible to recurrent attack with shorter durations in between the attack for hyperkalemia. Why hyperkalemia is a treatment barrier for patients with chronic kidney disease and heart failure? As we see, we will go through the KDOQI guideline regarding RAS therapy in patients with chronic kidney disease. As we see, in non-dialysis patients CKD without diabetes and proteinuria, they usually candidate for treatment with either ARBs or AC inhibitors. In non-dialysis patient with diabetes and either hypertension or proteinuria, the recommended medication for treatment usually ACE or ARBs, and we sometimes reach to the maximum dose of ACE or ARBs to reach the target reduction in proteinuria. So this retrospective analysis suggests that patients with hyperkalemia and underlying chronic kidney disease or congestive heart failure hardly reach to the maximum dose of ACE or ARBs. As we see, most of the patients got sub-maximum dose with stopping the treatment in about 15% of patients. So, are we optimally managing patients with hyperkalemia? As we see, if you got hyperkalemia, we usually go through changing RAS dose or stopping ACE or ARBs, or we don't do nothing, stopping the treatment which is beneficial for the patient, or shall we go for treatment of hyperkalemia which will solve this problem? There is limited evidence regarding the efficacy and safety of traditional potassium binders. As all of us know, in treatment of hyperkalemia, we usually start by low potassium diet, loop diuretic, discontinuation or reduction of RAS therapy, and finally we may use potassium binder like sodium polystyrene sulfonate or calcium polystyrene sulfonate. Unfortunately, the study done on potassium binder regarding sodium polystyrene sulfonate or calcium polystyrene sulfonate, the number of patients with is very small. The trial length was also very small, and the dose were quite big, and most of the patient does not tolerate this medication. Regarding Kayexalate or Resinocatin, as we see, most of the patient when start the treatment, they should continue for some time, but due to the side effect and non-compliance with the treatment, as we see, most of the patients stop this treatment maybe within months or within short duration of time. What about the newcomer Lokelma, a new solution? As we see, Lokelma is an organic crystalline zirconium silicate compound, insoluble, highly stable, does not expand in water, not systemically absorbed, and have high affinity for potassium, and usually the affinity for potassium exchange with sodium and hydrogen. As we see, potassium and hydrogen ion, owing to similar ionic diameter, fit best into Lokelma pool, leading to reduction in the serum potassium level. What about Lokelma efficacy and safety? Let's start our presentation regarding efficacy and safety by this gentleman, 52 years old man, type 2 diabetes with nephropathy, CKD stage 3, with other comorbid conditions including hypertension, hyperlipidemia, gout. The blood pressure was in the hypertensive side, and the patient serum potassium 5.2 milli equivalent with serum creat 1.8 and estimated GFR 40 ml per minute. This study was, we'll go through important study, starting by harmonized study and going through extension study. Harmonized study is a phase 3 multi-center 2-phase prospective study in patient with serum potassium more than 5.1 millimole at 44 nephrology, cardiology, general research site in the United States, South Africa, and Australia, starting by 48-hour correction, giving the patient Lokelma 10 grams 3 times daily. If the patient achieve normokalemia within 24 hours, we'll go through 28-day maintenance and 2 arms for 28-day maintenance, either placebo or Lokelma with different doses, starting by 5 grams once daily, 10 grams once daily, 15 grams once daily. Extension phase include the patient who complete harmonized phase at 30 sites in the US, South Africa, and Australia. It was 11 months maintenance, open label phase study using Lokelma 10 grams once daily, and if the patient got within target serum potassium, we can reduce the dose to 5 grams daily or 5 grams every other day in the maintenance phase, or in the extension trial. Regarding the primary endpoint in harmonized comparison of the mean serum potassium level between placebo and each Lokelma treatment group for day 8 to day 29, and the secondary endpoint change from the baseline in serum potassium level at all time interval, proportion of patients achieving normokalemia by 24 and 48 hours, and the time to potassium normalization. What about the primary endpoint for extension is the proportion of patients with mean serum potassium less than 5.1 millimole during 11 months maintenance phase, and the secondary was proportion of patients with average serum potassium less than 5.5 millimole during 11 months maintenance phase. What about onset of action in Lokelma? One dose of Lokelma significantly reduced serum potassium level at 1 hour at the baseline by about 0.2 milli equivalent of potassium, and 98% of patients achieved normokalemia during 48-hour correction phase. As we see, reduction in serum potassium start by the first hour about 0.2, reaching 4 hour 0.5, and by the end of the 48-hour reduction in serum potassium by about 1 milli equivalent. Lokelma sustained potassium control for up to 1 year. 88% of patients receiving Lokelma maintain an average serum potassium of less than 5.1 milli equivalent over 11 months. And no dietary restriction were imposed in this group of patients, and patients were instructed to continue their usual diet without any specific alteration. What about the reduction in serum potassium across different patient type? As we see, there is reduction in the serum potassium in all group of patients, reduction in the serum potassium in CKD patient, reduction in the serum potassium in patient with heart failure, diabetes, and patient taking RAS blockade. What about RAS dosing during the study? As we said before, hyperkalemia is a limiting factor for reaching the maximum dose of RAS blockade or AC inhibitor. Of the 38% of the 38 patients who have RAS naive at extension phase baseline, 11% initiated RAS therapy, and of the 83 patients who received RAS therapy at the start of the extension maintenance phase, 78% of the patients maintained the same RAS dose without a change in the serum potassium level. 4% of the patients discontinue RAS, and 8% increase the dose, reaching to the maximum dose of RAS therapy. So controlling hyperkalemia give us the chance to reach the maximum dose or maximally tolerated dose of RAS therapy or AC inhibitors. What about the safety and the tolerability profile in clinical trial? About 5.7% of patients receiving Lokelma report edema-related event. The event were more commonly seen in patients treated with 15 grams, which is considered to be a big dose for Lokelma, and so far the European Union does not approve 15 grams as a maintenance dose for Lokelma. No clinically significant changes in urinary sodium, magnesium, and calcium level was observed with Lokelma. 4.1% of patients receiving Lokelma develop hypokalemia, which resolve with dose adjustment or discontinuation of Lokelma. No significant drug-drug interaction with different medication may be used in this group of patients, like amlodipine, clopidogrel, furosemide, warfarin, and losartan. What about the patient? We start by his case scenario at the first. He is nowadays on Lokelma, 10 grams for 3 times per day for the correction phase, maintained later on 5 grams per day, and he start losartan, reaches a maximum dose of losartan. Nowadays, serum potassium 4.9 millimole on 10 grams of Lokelma per day, stable serum creat, and the patient have a more liberal potassium intake. What about patient on regular dialysis and sometimes they got high serum potassium level? What is next? The prevalence of hyperkalemia is 2.4 times higher prior to dialysis after the long interdialytic interval compared to short interdialytic interval. يعني الفترة اللي ما بين الدياليسيس, especially the 3 days between the dialysis or the long interdialytic interval, usually have a high risk of hyperkalemia, and the mortality and major adverse cardiovascular events usually increased during this period. And as we see, within 6 hours after hemodialysis, patient start eating and return to begin hyperkalemia, as we see from this prospective study of 14 patients with end-stage renal disease receiving hemodialysis 3 times weekly. As we see, 6 hours after finishing dialysis, serum potassium usually starting to increased. This study, dialysis study, a phase 3B randomized, double-blind, placebo-controlled study of Lokelma for reducing the incidence of pre-dialysis hyperkalemia. As we see, study design, patient aged more than 18 years on hemodialysis 3 times weekly for more than 3 months, and pre-dialysis hyperkalemia. 2 arms, Lokelma, number of patients was 97 and placebo was 99, and the post-treatment follow-up period was about 1 month. The result of the study endpoint, primary endpoint, percentage of patients maintaining serum potassium of 4 to 5 millimole during more than 3 or 4 hemodialysis treatment following long interdialytic interval and who did not require rescue therapy during the 4-week evaluation period. Second endpoint, efficacy and safety, including proportion of patients requiring rescue therapy to reduce serum potassium, adverse events, and interdialytic weight gain in between the dialysis session. As we see, the primary endpoint, the proportion of responder was significantly higher with Lokelma than placebo. Sensitivity analysis results were consistent with the primary analysis, and as we see, there is marked reduction in the serum potassium level with Lokelma. In summary, dialysis is the first randomized placebo-controlled trial to evaluate the efficacy and safety of potassium binder in treatment of hyperkalemia in patients with hemodialysis. The study met its primary endpoint by demonstrating that significantly more patients with Lokelma maintained on pre-dialysis serum potassium between 4 to 5. There was no difference between Lokelma and placebo in interdialytic weight gain. Lokelma was well tolerated with most adverse events mild to moderate in intensity. The adverse event profile between the treatment group were similar, including GI adverse event and hypokalemia. So, if we are going to repeat our thinking according to the guidelines in management of hyperkalemia, as we see, chronic kidney disease and heart failure treatment guideline recommend RAS therapy to improve patient outcome. RAS therapy should be initiated and titrated to the highest approved dose that's tolerated. Despite the proven benefit of RAS therapy, hyperkalemia can be a barrier to achieving and maintaining guideline recommended dose. Based on the current evidence, CKD and heart failure treatment guideline now include the use of novel potassium binder as an option for controlling potassium to enable optimal RAS therapy. So the clinical sequence of hyperkalemia, as we said before, hyperkalemia in patients with CKD and congestive heart failure usually leads to increased morbidity and mortality risk and leads to suboptimal RAS therapy. If we broke this circle, kidney binders may break the circle, leading to normokalemia and RAS optimization, reducing morbidity and mortality risk. So, as we said before, as shown in the clinical study in the real world, Lokelma can be used to treat hyperkalemia while optimizing guideline recommending RAS therapy. There is ongoing two important study, realized potassium study in patients with congestive heart failure under spironolactone treatment, and the result will be released in 2024, and stabilized CKD patient. This group of patients with reduction in the estimated GFR, and they are taking different type of ACE and ARBs. The number of patients around 1,500 patients, and I think the result will be also released in 2025. What about the change in the guideline in patients with heart failure? Guidelines state that the use of potassium binder to manage hyperkalemia, which may enable RAS therapy. 2021 European Society of Cardiology guideline for the diagnosis and treatment of acute and chronic heart failure. RAS therapy should be optimized when potassium level are below 5 milliequivalent. An approved potassium lowering agent may be initiated as soon as potassium level are confirmed as more than 5 millimole, and with close monitoring of the serum potassium and serum creatinine. Also, American Heart Association and American College of Cardiology 2022, they said that Lokelma and Batirumor have been shown to lower potassium level and enable treatment with RAS therapy in patients with heart failure. What about patients with CKD, hyperkalemia associated with ACE and ARBs? Use can be often managed by measure to reduce potassium rather than decreasing dose or stopping ACE and ARBs. Regarding chronic hyperkalemia, starting by dietary potassium restriction, discontinue potassium supplement, add potassium wasting diuretic, and finally we can add oral potassium binder. So the recommendation is that Lokelma is recommended an option for treating hyperkalemia in adult only if used in emergency care for acute life-threatening hyperkalemia alongside standard of care for people with persistent hyperkalemia and chronic kidney disease, stage 3B to 5, or heart failure if they have confirmed serum potassium level of at least 6 millimole per liter, and because of hyperkalemia are not taking an optimized dose of renin angiotensin aldosterone inhibitors. So Lokelma is a treatment for people with high potassium level. The cost effectiveness estimates of sodium zirconium cyclosilicate suggest that it is a good use of National Health Services and resources in England, and it may allow people to stay on RAS inhibitors for longer duration of time, which may lead to extension of life and improve quality of life. And these are the different doses of Lokelma. Thank you very much for your attention.